questions you ask is how to know if antidepressants work for me or which ones to take. And people might be wondering that about themselves or their children or their parents. How do you know if it's right for you? And we'll move on to the other things that you can consider both with antidepressants or instead of. But if you're first considering whether to take them, and I think people have worries about them, how do you know?
Yeah, I sympathize very much with this worry. And I think that with every medication, it shouldn't really be down to the patient to decide, to kind of be faced with this really difficult decision. They should be guided by their clinician. And I very much hope that anyone making that decision has a GP or has another kind of medical professional they can talk about this with. Because at the end of the day, it's a decision that will involve many factors, including, do they have access to other possible treatments? Have they tried antidepressants before? Have they worked or not worked? Which type have they tried? What are their exact set of symptoms? I mean, an immensely kind of complex set of things. And even then, it will only lead to a kind of suggestion of what might be the right next step. Now, I think in sort of my ideal world, if I were making a decision to take antidepressants, what I would really like is some kind of estimate, like a statistical estimate of what would be my best shot, if a drug, which drug, and so on. We don't have that right now, but I know labs around the world that are working on that kind of personalized algorithm to tell you which treatment would be best for you.
It's really interesting. You talk about other drugs, and I'm sure many people have questions about this. You talk about alcohol, you talk about the whole selection of drugs that are suggested these days or have been conventionally thought of as ways to ease stress or anxiety. But I'm going to ask you about psychedelics because there's a lot, again, a lot of discussion around psychedelics. And you say that there's no harmful, I think I've got this right, no harmful effects really of psychedelics. Lots of research suggesting multiple benefits for their mental health. I've read endless articles now, I think, about particularly psilocybin. Are you convinced of their efficacy?
Yeah, I wouldn't go so far as to say there are no harmful effects. I cite a really useful study about kind of societal and individual harms relative to other drugs and relative to other recreational drugs.
Yeah.
Psilocybin is a very safe drug. So if you think about it relatively, it does very well compared to something even like alcohol. But having said that, that doesn't mean that there aren't personal risks of personal harms, which is something I actually think has been somewhat overlooked by the discussion around psilocybin treatments for mental health conditions. So people are excited by new treatment. Of course they are. And I think, there are trials to suggest that perhaps we should be excited. Perhaps it is a new type of drug that we could add to our mental health arsenal of treatments in the future. However, I also think that because of the nature of this drug, people have been so excited that they've maybe overlooked two problems. And one problem is the problem that for some people, it is absolutely not the right treatment. And we need better work to figure out who those people are and to ensure targeted treatment efforts do not go towards patients who will end up with very challenging side effects, very difficult adverse events during the experience. So this is a kind of anecdotal thing because I don't think it's been investigated quite enough, but there are patients who've been in various psilocybin trials who've later spoken up about adverse effects of the drug. So I think even if it's a small minority, it's a minority that's very important to investigate. And actually, I don't really know if it's a small minority because it needs to be investigated more robustly. And then the second thing that I would really like to see more work on is a kind of fairer trial of psychedelic drugs. So at the moment, most trials happening of psychedelic drugs, you know it when you're on it. It's too difficult to blind. It really is challenging. But I actually think that decoupling a placebo effect, what's happening when you anticipate the effects of a psychedelic drug, from the actual biological kind of additional effects of those psychedelics, I think that's really, really important, and more work needs to be done in that space.
I mean, I don't want you to force you into saying anything controversial, but it's incredibly frustrating to read you say that it's incredibly difficult to get research licenses to do research into psychedelics, and they desperately need more study, as you've just said. And if they are possibly an extraordinary cure and they can help lots of people, why is there a reluctance and not more going into that funding from governments into those things?
I actually think this is something that's changing as we speak. So there are many more labs researching psychedelics now than there ever have been in the past. When I started work kind of in mental health neuroscience, which was over 10 years ago, it was so rare to see research like this, to see labs investigating psychedelics. And today it's much, much more common. So I think there have been many moves in the right direction. But I also think that in order to acquire funding and to kind of sustain funding in this area, we as scientists have a responsibility to do the best and most robust science we can with these substances, which might mean different sorts of labs doing investigations. It might mean more publishing of null results, which means results where you don't find an effect. There isn't sort of one solution, but I do think that kind of as investment increases in this area, we need to be aware and cautious that it's not just investment in kind of translating it to the public. We also need to be doing the basic science, the fundamental work to say, does it work? Who does it work in? What should we look out for? Just like with other treatments, we shouldn't be treating it any differently than a new kind of antidepressant drug.
Yeah. Well, I'm gonna go past some of the other drugs because there's so much more to talk about, and I want to talk to you about various other sorts of treatment. Again, I'm sure lots of people know people considering these, might be considering them yourself, and you write so helpfully about the psychotherapy changing the brain, and in terms of CBT, which you say reigns supreme as a type of psychological therapy. So again, you've helped us so much in describing who benefits from certain treatments. Perhaps you could explain CBT and the behaviorism and cognitivism, and how you know if CBT is for you. Is it for everybody?
Well, probably if you've been to a therapist or various therapists, you've probably experienced some aspects of CBT yourself, even if that wasn't what it was called, even if it was introduced slightly differently, because it's been so influential in the therapeutic sphere, especially for depression. Now, I should say there are many arguments amongst therapists whether it should be considered the gold standard for depression and other disorders, but it is. That's the reality. So that's kind of where current, majority opinion is, or majority, that's what the NHS does in the IAPT service for depression. So there are many kind of demonstrations of why it's so commonly used, even if you want to debate whether it should be like as common as it is. And what actually happens, and what's so interesting about cognitive behavioral therapy, is that an individual patient has, say, a set of challenges that they are experiencing. Maybe they have social anxiety. Every time they go to a party, they feel incredibly anxious, and it's kind of exacerbated and built up, and now they feel that they cannot even leave their house without experiencing those kinds of anxieties about interacting with people. And in a course of CBT, a therapist will work with them both on the thoughts that are leading to those anxieties. What are perhaps the catastrophizing or negative patterns of thinking that are leading to those concerns, as well as encourage, often gradually, behavioral changes. Maybe a behavioral experiment, it's called, where you do something close to what you find very anxious and then report back to the therapist on how it went. And the way this, you might say, is this neuroscience? And in fact, it works by very similar brain processes to the other mental health treatments that I've described. It gets at them in a slightly different way, because what CBT is doing is affecting how you learn about the world, what you learn about the world, and also your general beliefs about the world. So that kind of final step of what an antidepressant might be changing is also what CBT is working on, kind of encouraging you to perhaps experience the world in a way that eventually has fewer kind of negative expectations about what will happen in some contexts.
And that's something that, if you're considering it, you need someone else to do with you, a trained psychotherapist.
That's it up for a debate. So there have been some studies doing different kinds of psychological therapy online and shown reasonable efficacy. So you might need someone else, but they might not have to be in person. And then there's a kind of, you know, a real sort of downstream effect of that. Could that person be a bot? So, you know, some companies in particular are investing in sort of artificial intelligence techniques for therapy. And could that be sort of you teaching yourself? There's some evidence that can be helpful. But ultimately, yes, the most kind of effective trials are done with trained therapists who've often trained for quite a long time to deliver this kind of therapy.
Yeah. And I was so interested that you almost say that that's teaching you how to think about the world and to interact and to think very carefully about how you interact with the world. And almost the antithesis of that is mindfulness, which you then write about, which is to say, I don't care, to try to care less, to try not to analyze your thoughts, you know, not to overthink it, as people are always saying to me about various things. Do you combine the two? I know you say in the book, you're very honest about how difficult you find mindfulness, but people find it very, very helpful. You know, I certainly think it's a really calming and extraordinary thing to do very simply. Do you think that people should be both interrogating the way they think about the world and trying not to care so much?
Yeah, there probably is some optimal combination. And I certainly know, you know, individual therapists or therapeutic strategies that integrate both and tailor it for particular people and what they might find useful. I think mindfulness is actually such an interesting example of a therapy that works in a slightly different way than CBT, but can still be very, very effective. And there may be different camps of people who not just prefer one over the other, but in fact respond better to one or the other. And I think that's another really interesting area for investigation, a little bit like finding, you know, which drug works for you, also which therapy works for you. That would be something very useful to know before you undertake like a 16-session, months-long treatment.
So does that mean, I mean, as you say again in the book, everything works for different people. For some people, it might be psilocybin. For some people, it might be having a glass of wine. For some people, it might be CBT. For some people, it might be this. I mean, is the only way at the moment to experiment a bit with those, each one, or?
Well, I think what many people do pragmatically is experiment with different techniques to improve their mental health. But I also think there is a responsibility on scientists, on kind of clinician scientists, people working in my space, to really push forward our ability to identify which treatments work for which people. And there certainly are examples around the world of really innovative labs and treatments trying to match people with the right treatment. And I think that is an area we're going to see a lot of improvement in the future. And one suggestion, you know, maybe like a little bit of a more controversial suggestion I make in the book, is that something that could be helpful to that end is identifying mechanisms that are disrupted in individual people. This could be maybe with a computer task, with a mobile phone, there could be with a bunch of questionnaires, many different ways, a blood test, a brain scan, so many ways to measure underlying processes. But in my view, those processes are more likely to be able to pair with an individual treatment that we know targets those, rather than something like a diagnosis of depression, which is a very, very general descriptor where two people with entirely different sets of symptoms might both meet criteria for that diagnosis. Useful for them to know, useful for a clinician, but actually for treatment, we might need to go beneath the surface and find out what is driving that person's depression or that person's phobia or that person's anxiety in order to work out what the right treatment for them is.
Mm. And talking of treatments, I was very surprised to read, or saddened in a way, just the unbelievable power of public perception when you write about ECT, which I'm sure many people will know of, and I think is far more rarely used as a treatment. And you say it is without doubt the most effective treatment for depression. But the reason that we see it used less and less despite that is because of public perception. I think one professional doctor said to you that science has just lost the public battle with ECT. So is that really more and more a thing of the past?
Yeah, I was a bit sad to learn that as well, because like you, I had a misconception about ECT when I first started working in this field. And I don't want to say that that's for no reason. There is a really good reason why we all have a misconception about ECT, because the kind of, really early stages of this work were done sometimes, without people's consent, often in very different contexts to very different degrees than it has been done in the recent past. And in fact, ECT is still a treatment that's used and very effectively used. As I say in the book, it is the most effective treatment for very severe depression. So this is people who haven't responded to anything else. And the reason you would want to use it on that group is because there can be serious side effects that are important to know about. For example, memory loss, particularly around the time of treatment. Although the kind of robust studies show that this lessens as soon as you get a few weeks away from treatment, and you can even see sort of benefits compared to before treatment, because depression itself often comes with serious memory impairments. So overall, I think the weight of the evidence is in favor of ECT for people with very severe depression, but I do certainly have an understanding for why people are so resistant to that idea. Even people who've individually, personally had very negative experiences of ECT, I totally sympathize with the idea that they feel that they shouldn't have had it. This is a personal experience. That just maybe doesn't line up exactly with the kind of group experience of the evidence, but is still very important to listen to. So yeah, so that's why I wanted to discuss ECT in the book. It was a kind of very it's not a topic my lab researches, because almost no labs that I know of in neuroscience research ECT. I don't know funding bodies handing out money to research ECT. Instead, I think many people have turned to other forms of brain stimulation, as the clinician that I described in that anecdote suggested, and as my lab has worked on since, kind of other forms of brain stimulation.